Welcome back to the Deep Dive. Today, we are really getting into something fundamental. We're plunging into the nutritional blueprint for maybe the most critical year of life, infancy. Our mission today, to distill the key knowledge from our source material on nutrition through the life cycle. We're focusing specifically on healthy full-term infants, those first 12 months. If you want to understand how nutrition literally builds a human from the ground up, well, this deep dive is for you.
And it's built at staggering speed. Infancy, it's just the most rapid growth period in the entire human lifespan. Think about it. A baby usually doubles their birth weight by, 4 to 6 months?
Yeah.
And triples it by their first birthday.
Triple in just 1 year.
Oh,
it's incredible. And we often just focus on the size, the weight gain, but the sources really stress something else too. Nutritional adequacy in this window, it isn't just about getting bigger. It's laying the groundwork for, everything else. Cognitive function, motor skills, even socio-emotional development. The stakes are just so high.
Absolutely. That's why understanding the precise needs, the developmental windows, it's just crucial. So we're basically going to cover, let's say, 4 main areas today. First, how do we even know if an infant is growing correctly? Assessment.
Okay.
Second, what specific fuel do they need? The energy, the nutrients.
Right.
Third, how does their physical development, their motor skills, actually affect how they eat?
The practical side.
Exactly. And finally, how do you handle those, common nutritional bumps in the road that inevitably pop up?
Got it. Sounds like a comprehensive plan. Let's dive into that first part then, assessment.
Right.
So the basics. The sources define a full-term infant as one born between 37 and 42 weeks gestation.
Uh-huh.
And typically weighing somewhere around 2,500 to 3,800 grams. That's about 5.5 to 8.5 pounds for us non-metric folks.
That's the typical range, yeah. And those two things you mentioned, gestational age and birth weight, they're far and away the most important predictors of survival and, frankly, later health outcomes.
Okay. And the sources mention specific terms too, right? Like SGA and LGA.
Yes, important classifications. If a baby plots below the 10th percentile for weight at their gestational age, they're small for gestational age, SGA.
Okay.
And if they're above the 90th percentile, they're large for gestational age, LGA. These aren't just labels. They help us anticipate potential health challenges right from the start.
Right. Flags potential issues.
Okay.
So once the baby's born and home, tracking that growth is key. But you said it's surprisingly specific how we measure.
No, absolutely. You need frequent, accurate measurements. We're talking weight taken nude on a calibrated infant scale.
Not the bathroom scale then.
Definitely not. And length, measured recumbent, meaning lying down on a proper length board. And head circumference, measured at the widest part of the head.
Precision matters, because fuzzy measurements could mask a problem. Or maybe even create worry where there isn't one.
Exactly right. Which brings us to the tool we use to interpret these measurements. The World Health Organization, or WHO, growth charts. These are recommended for infants from birth to 24 months. And here's a really key point that often gets missed. The WHO charts aren't just based on average babies.
Oh.
No, they're based on how infants should grow under ideal conditions. The data comes primarily from breastfed infants raised in supportive environments.
Wait, hang on. So the charts are setting a benchmark, like the physiological potential for growth, not just a statistical middle ground.
Precisely. It represents the optimal trajectory. So if you see an infant consistently falling off their percentile curve, or maybe showing no gain in weight or length for a period,
That's a major red flag.
it's a major warning sign, yes. It suggests the infant isn't meeting their growth potential. It's a really powerful distinction in how we interpret growth.
Okay, that really reframes how we look at those charts. Now let's connect this growth to the baby's internal development, your physiology.
Right. So a newborn's central nervous system, it's still pretty immature, which is why their hunger and fullness cues can be quite subtle. A little hand sucking, turning their head to root around, maybe just getting a bit fussy.
But even with that immaturity, they arrive ready to eat, thanks to some built-in reflexes.
They do. Key protective reflexes are already wired in. The main ones for feeding are rooting, humming. That's when they turn their head towards a touch on the cheek, searching.
Like seeking the nipple.
Exactly. And suckling, which is that initial rhythmic back and forth tongue movement. And amazingly, they can coordinate sucking, swallowing, and breathing right from the get-go.
It really is incredible design. And other reflexes, like the startle reflex, the morones, a grasping, they fade over time.
They do. They make way for more purposeful motor skills. And those emerging motor skills directly impact energy needs and feeding ability.
How so?
Well, think about the progression. At 1 month, maybe they can lift their chin briefly. By 7 months, they're sitting unsupported, maybe walking around 15 months. Each step demands significantly more energy. And crucially, that ability to sit up stably to control their head and trunk, that's the absolute prerequisite for safely starting solid foods in a high chair. You need that postural stability.
That makes sense. This also ties into something the sources call critical periods, doesn't it?
Yes, a very important concept. A critical period is a specific fixed time window when a particular behavior or skill is supposed to emerge. Take oral feeding skills. If an infant has prolonged discomfort or negative experiences around feeding during this critical window, maybe they're on respiratory support or have reflux pain, that can unfortunately lead to lasting feeding disinterest or aversion. Once that developmental window closes, it can be much, much harder to establish positive feeding behaviors later on.
So the timing is everything. Okay, let's move to the fuel needed for all this growth and development. Section 2, energy and nutrients.
Right, the fuel. And they need a lot of it. Energy needs per kilogram of body weight are higher in infancy than at any other point in the entire lifespan.
Really? How high are we talking?
The range is typically 80 to 120 kilocalories per kilogram per day. The average is around 108 kilogram for the first 6 months, dropping slightly to about 98 kilogram for the second 6 months.
Wow. Just for comparison, what might an adult need?
Yeah.
Like 30, 35 kilocalories?
Something like that, yeah. It's a massive difference, and this incredibly high metabolic rate explains a key vulnerability.
Okay.
Infants just cannot tolerate long periods without feeding. They burn through their limited carbohydrate and fat stores very, very quickly.
And what happens when those run out? What does the body do?
It switches gears into something called catabolism. It starts breaking down amino acids, pulled mainly from body protein, to make glucose for energy.
So it's sacrificing building blocks.
Exactly. The protein that should be going towards building new muscle, new tissues, new brain cells, is instead being burned for immediate fuel. This is fundamentally why young infants have to wake up frequently to feed. They're biologically protecting their growth.
That explains why you can't just train a very young baby to sleep through the night before they're ready. Okay, so protein needs are high, but timing matters.
It does. And while the requirement per kilo drops slightly after 6 months, caregivers need to be careful. Improperly mixing formula, like adding extra scoops or putting cereal in bottles, can lead to excessively high protein intake. And that puts a real strain on their immature kidneys.
Good warning. Okay, what about fat? We hear so much negativity about fat as adults.
But for infants, it's absolutely vital. Fat provides somewhere between 40 and 50% of the calories in breast milk or formula.
Half the energy.
Pretty much. And it provides those crucial essential fatty acids you hear about, DHA and ARA, which are non-negotiable for rapid brain and neurological development. The source material is crystal clear on this. Dietary fat and cholesterol restriction are absolutely not recommended in infancy, period.
Okay, message received. No skim milk for babies.
Let's turn to micronutrients. You mentioned 2 big ones where infants are particularly vulnerable. Yes, the big 2, as you called them. Iron and vitamin D. Let's start with iron. This is a massive concern. Why? Because between 4 and 12 months of age, an infant's blood volume literally doubles.
Doubles, wow.
Yeah. And that requires a huge amount of iron to make all that new hemoglobin. Now, a full-term baby is born with iron stores they built up from their mother during the 3rd trimester.
Right.
But those stores typically only last about 4 to 6 months. And then the requirement skyrockets. It jumps from a tiny adequate intake, or AI, of 0.27 milligrams per day in the first 6 months to a recommended dietary allowance, or RDA, and a whopping 11 milligrams per day from 7 to 12 months.
11. That's a huge leap. So wait, if breast milk is supposed to be the perfect food, how come breastfed babies run out of iron around 4 to 6 months?
It seems counterintuitive, doesn't it? It's one of nature's sort of trade-offs.
Right.
The system relies heavily on those initial stores from pregnancy. Once those are depleted, breast milk, while amazing in many ways, simply doesn't contain enough iron to meet that dramatically increased need.
So what's the solution?
The intervention is clear and evidence-based. Exclusively breastfed, full-term infants need an iron supplement. Specifically, 1 milligram of iron per kilogram of body weight per day, starting at 4 months of age.
Starting at 4 months. Until when?
Until iron-rich complementary foods like fortified cereals or pureed meats are being regularly consumed and providing enough iron.
And why is this so critical?
Because the consequences of iron deficiency, especially iron deficiency anemia, during this rapid brain development period can be severe and long-lasting. We're talking potential learning delays, problems with socio-emotional development, things that might not be reversible. It's too important to risk.
Okay, iron supplementation for breastfed babies at 4 months. Got it. What about the second one, vitamin D?
Similar kind of situation, actually. Vitamin D is essential for calcium absorption and bone mineralization, building strong bones.
Right.
And breast milk, again, while wonderful, is naturally quite low in vitamin D. The AI for infants is 10 micrograms, which is 400 international units, or IU, per day.
So another supplement needed.
Yes. The recommendation is that all breastfed infants, and partially breastfed infants too, need a 400 IU per day vitamin D supplement, starting shortly after birth, basically from the first few days of life.
All of them. Wow. What about formula-fed babies?
Infant formula is fortified with vitamin D. So formula-fed babies are usually okay if they're consistently drinking about a liter or roughly a quart of formula per day. If they drink less than that, they might need a supplement too.
Good to know. Okay, quickly. What about zinc and fluoride? Are they concerns?
Zinc is definitely important, crucial for growth and immune function. The AI is based on typical intake from breast milk. The main strategy after 6 months is dietary, making sure to introduce zinc-rich complementary foods, things like red meats, poultry, beans.
And fluoride.
Fluoride's role is in preventing dental caries, cavities. Supplementation is only recommended starting at 6 months if the family lives in an area where the community water supply has low fluoride levels. Otherwise, they likely get enough.
Okay, that covers the key nutrients. Let's shift gears to section 3, how babies actually learn to eat.
Right, mastering the art of feeding. And the core concept here is responsive feeding.
Responsive feeding, what does that mean exactly?
It's really about a reciprocal relationship, a back-and-forth dance between the parent or caregiver and the infant. The caregiver learns to recognize the infant's hunger and fullness cues and responds appropriately, promptly, warmly, and consistently.
It's more than just feeding whenever they try that.
Oh, much more. It's about tuning into their communication. Early hunger cues might be subtle, sucking on a fist, rooting around, maybe increased alertness. Later, as they get older, they might actively reach for the spoon or point to food.
And fullness cues are just as important to recognize.
Absolutely critical. Things like sealing their lips tight, turning their head away consistently, pushing the food away, slowing down the pace of eating, or even starting to play with the food instead of eating it.
So responsive parenting and feeding means paying attention to both ends, hunger and fullness.
Exactly. And creating a positive feeding environment. Pleasant, relaxed, minimal distractions, definitely no screens during meal times. It's about balancing, helping them with encouraging them to develop their own skills as they get older.
Okay. Now, the big transition, starting solids.
Yeah.
Or, as the sources call them, complementary foods. When does that usually happen?
So, complementary foods, defined as any foods or fluids other than breast milk or formula, are generally introduced after 6 months of age.
Why 6 months?
Because up until about 6 months, breast milk or formula typically provides all the nutrients and energy a healthy term infant needs. After 6 months, their energy and nutrient demands, especially for things like iron and zinc, start to outpace what milk alone can provide. But timing isn't just about age. Readiness is key. The infant has to show developmental signs they're ready.
Like what?
They need good truncal stability, meaning they can sit up well, mostly independently, with good head control.
Right, for safety in the high chair.
Absolutely. Those early infant reflexes, like the tongue thrust reflex, should be diminishing or gone. And they need to have developed the oral motor skills to actually manage food that isn't liquid, moving it back to swallow.
Okay, let's talk about that tongue thrust reflex, that thing where they seem to just push the food right back out. Is that them saying, I don't like this?
Not usually, especially at first. That forward-pushing motion of the tongue is often just the extrusion reflex doing its thing. It's a protective reflex that helps prevent choking in very young infants.
Oh.
As they mature, that reflex fades, and they learn to use their tongue to accept the spoon and move the food backwards to swallow. It takes practice.
So parents shouldn't get discouraged if the first few spoonfuls seem to come right back out.
Exactly. It's part of the learning process. And that's why the recommendation is to introduce only one new single-ingredient food every 3 to 5 days.
Why the wait?
It gives you time to see how the baby reacts. Is it just the extrusion reflex? Or is it a sign of a potential allergy or intolerance, like a rash or vomiting or diarrhea? Spacing foods out helps you pinpoint any problems.
That makes the pacing rule much clearer. It's not just about taste preference. What about different feeding approaches? We hear a lot about baby-led weaning.
Yes, baby-led weaning, or BLW. It's an alternative approach, also starting around 6 months when the baby shows readiness signs. Instead of starting with purees on a spoon, the focus is on infant self-feeding.
How does that work?
You offer soft, graspable pieces of food, think the size and shape of an adult pinky finger initially, that the baby can pick up and bring to their own mouth. Things like steamed carrot sticks, soft ripe pear slices, strips of toast.
And what do the sources say about safety? Is it riskier for choking?
That's a common concern. But the evidence, as presented in the sources, suggests that when done correctly, meaning offering appropriate textures and sizes and always supervising BLW, is not associated with a higher risk of choking compared to traditional spoon feeding.
Interesting. But purees are still okay.
Oh, absolutely. Whether you start with purees or BLW, experiencing a variety of textures, including smooth purees, lumpy foods, and soft solids, is important for oral motor development. It's not necessarily an either-or situation.
Good point. Before we leave feeding, what are the absolute must-avoid things for infants under 1 year?
Number one, biggest avoidance: cow's milk as a primary drink before the age of 1 year.
Why is that?
Several reasons. It's relatively low in iron, and it can actually irritate the infant's gut lining, potentially leading to small amounts of blood loss, which further contributes to iron deficiency anemia. It's also too high in some minerals and protein for their immature systems.
So, no cow's milk in the bottle or sippy cup until after their first birthday. What else?
Avoid 100% fruit juice completely before 12 months. And definitely no sugar-sweetened beverages ever, really, but especially not in infancy.
Why no juice, even 100% juice?
It offers no nutritional advantage over whole fruit. It displaces intake of more nutrient-dense breast milk or formula, and the sugar contributes significantly to the risk of early childhood caries or cavities. Water and milk, breast milk or formula, are the only drinks they need.
And plant-based milks, like almond or oat milk.
Generally, no. Most plant-based beverages are nutritionally inadequate as replacements for breast milk or formula during infancy. They lack the right balance of protein, fat, vitamins, and minerals.
Okay, strong warnings there. And briefly, the choking hazards list. Things to absolutely keep away.
Yes, crucial for safety. Avoid small, hard, round, or sticky foods. Think whole grapes, hot dog rounds, nuts and seeds, raw carrots or celery, popcorn, hard candies, spoonfuls of peanut butter. Always cut food into appropriately small pieces and supervise constantly during eating.
Got it. Safety first. All right, let's move into our final section, common nutritional issues and how to handle them.
Okay, section 4. Let's tackle some common hurdles. First up, colic. The word strikes fear into many new parents.
Rightly so. How do the sources define it?
It's generally described by the rule of threes. Crying for more than 3 hours a day, for more than 3 days a week, for more than 3 weeks. Usually in an otherwise healthy infant, often starting in the first few weeks and resolving by 4 or 5 months.
And the cause.
Frustratingly, there's no single definitive cause identified. It's likely multifactorial. Interventions mostly focus on parental coping and calming techniques: swaddling, rocking, white noise.
Does changing diet help?
Sometimes. If the mother is breastfeeding, eliminating cow's milk protein from her diet might help in some cases. For formula-fed infants, switching formulas might help, but often it doesn't make a significant difference. It's often a waiting game, unfortunately.
Okay. What about more straightforward digestive issues like diarrhea or constipation?
Diarrhea is a big concern in infants, mainly because of the high risk of dehydration. The key treatment is to continue feeding, don't stop breast milk or formula to provide fluids and energy. Oral rehydration solutions, like Pedialyte, are useful for replacing fluids and electrolytes quickly, but they are very low in calories, so they're meant for short-term use alongside regular feedings, not as a replacement.
And constipation?
Usually managed by ensuring adequate fluid intake. Once complementary foods are introduced, making sure they get appropriate fiber sources can help things like pureed pears, prunes, or oatmeal. But again, always be mindful of choking hazards when considering fiber sources.
Right. We talked about iron deficiency anemia earlier, but let's just quickly reiterate the main risk factors parents should be aware of.
Absolutely. The biggest risks are low birth weight. Preterm infants have lower iron stores. High intake of cow's milk after 6 months but before age 1. Low intake of iron-rich complementary foods. And sometimes low socioeconomic status can be associated with reduced access to iron-rich foods.
And again, the prevention is key, that 4-month iron supplement for breastfed babies.
Crucial preventative medicine, yes, to avoid those potential long-term cognitive impacts.
Okay, another issue, Early childhood caries, or ECC, cavities in baby teeth.
Yes, unfortunately common. Big risk factors include frequent consumption of sugary liquids, especially giving a bottle of milk, formula, or juice at bedtime or nap time, allowing the sugars to pool around the teeth. Frequent snacking on sugary or starchy foods also contributes.
Prevention.
Start oral hygiene early, wipe gums with a soft cloth even before teeth erupt. Once the first tooth appears, start brushing gently with a tiny smear of fluoride toothpaste. And try to wean from the bottle between 12 and 18 months. Water only in bottles used between meals or at night.
Makes sense. Now, a really interesting topic where guidance has shifted dramatically. Food allergies.
Yes, this has been a revolutionary change in recent years. The basic mechanism of an allergy involves the immune system reacting to intact protein fragments that might get absorbed, perhaps through an irritated gut lining. We know there's a fairly high chance of cross-reactivity between cow's milk protein and soy protein. So, switching from a cow's milk formula to a soy formula might not solve an allergy issue.
Right, but the big news was about peanuts, wasn't it? From the ELEAP trial.
Exactly. The learning early about peanut allergy, or soft trial, fundamentally changed our approach. For decades, the advice was to delay introducing common allergens like peanuts.
Yeah, I remember that. Keep them away for years.
Right. But
Huh.
the LA trials showed the opposite might be true, especially for high-risk infants.
High risk meaning.
Infants with severe eczema or an existing egg allergy, or both. For these infants, the trial found that early introduction of peanut-containing foods, typically between 4 and 6 months of age, done carefully under medical guidance,
Yes.
significantly reduced their risk of developing a peanut allergy later on, dramatically reduced it.
Wow. So introducing it early prevents the allergy. How does that work?
The leading theory is about immune tolerance. Introducing the potential allergen early, especially through the gut, might help teach the developing immune system to recognize that protein as a normal food rather than as a foreign invader to be attacked.
Fascinating. So the guidance now actively encourages early introduction for those high-risk babies.
Yes, but always in consultation with a healthcare provider to determine the right timing and method, perhaps after allergy testing. For lower-risk infants, peanut introduction is generally recommended around 6 months, along with other complementary foods. It's a major paradigm shift.
Definitely. Okay, finally, let's bring this all together. How does all this early nutrition relate to preventing obesity later in childhood and life?
The strategies really start right here, in infancy. Promoting and supporting breastfeeding is one key strategy. But perhaps the most powerful tool is supporting the infant's innate ability to self-regulate their intake.
Self-regulate. You mean letting them decide how much to eat?
Essentially, yes. Trusting their internal cues. Feeding on demand, responding to those early hunger signs we talked about, and just as importantly, recognizing and respecting their fullness cues. Don't pressure them to finish the bottle or eat more than they seem to want.
Avoid the clean plate club mentality from day one.
Pretty much. Avoid using food as a reward or pacifier. Provide age-appropriate portion sizes. Ensure they get adequate sleep, which is also linked to weight regulation. It's about fostering that internal sense of hunger and satiety right from the beginning.
Setting them up to trust their own bodies.
Precisely.
Wow, that's a lot of ground we've covered. Any final key takeaways you want to leave us with?
Yeah, I think if you remember just a few things from this deep dive, let it be these. First, responsive feeding is paramount. Learn and honor those hunger and fullness cues. It builds trust and healthy self-regulation. Second, targeted supplementation is non-negotiable for many infants, especially iron starting at 4 months for breastfed babies and vitamin D right from the start for breastfed babies. Don't skip these. And third, use those WHO growth charts correctly. Understand they represent optimal growth potential and watch the trends carefully as an indicator of overall health. Infancy is just this incredibly dynamic period of vulnerability, but also immense opportunity.
Absolutely. And connecting all these pieces, what really stands out to me is how profoundly this first year shapes lifelong health and even behavior. The environment you create around feeding. It matters. The flavors an infant encounters, perhaps even through breast milk, depending on the mother's diet, the textures they learn to accept, the habits they observe around meal times, whether feeding is stressful or relaxed. All of this is actively programming their future food preferences and eating patterns. Think about that for a moment. How might establishing positive, responsive, non-pressured feeding interactions now influence the choices your child makes about food, their relationship with eating, maybe even their body image, years and decades down the road?
It's a powerful thought. Food preferences are largely learned, and those very first experiences lay the foundation. It really highlights the long-term impact of what happens in this short, critical window.
A foundation for a lifetime. A truly powerful concept to reflect on. Thank you so much for sharing your insights today.
My pleasure.
And thank you for tuning into this deep dive. We hope this knowledge serves you well on the journey through infancy.